Gentlemen, it is 1:30 and I'm going to call to order the Cumberland County Finance meeting. And we will begin with a roll call, please.
That's okay. Commissioner Niederberg?
I am here.
Commissioner Fashi? I'm here. Commissioner Eichelberger?
Thank you, Desiree.
You're welcome.
Next on the agenda, we open up for public comment. Is there anyone online wishing to make public comment? If so, please use the raise your hand feature.
No one's raising their hand this
No
moment.
one's anyone in the room wishing to make public comment at this time? It appears not. We will move into the approval of the minutes from November 13th.
I'll move to approve.
Moved and seconded. All in favor, say aye.
Aye.
Aye. Thank you. Next up, we have an update. Annie, are you going to help walk us through from our vendor connections on the Regional Crisis Walk-In Center?
No, I certainly can, but I
Okay.
think it's probably better to just introduce our partners
Please.
here. So this is Brittany McCarthy and Kimberly Jones, both from Connections Health Solutions, and Sarah Lopez is online. And they're going to be walking us through the updates. So I don't know if you
Okay,
guys wanna
perfect. Do you ladies
drive
want to both come up? You can grab another.
Oh, Sarah's gonna actually. Brittany's gonna take the push
Yeah.
in advance.
Good afternoon,
So long
everyone.
as some-
Can you guys hear me okay?
Yep, perfect.
Great. We appreciate the time. Thank you so much for allowing us to give an update. I will say in advance that I believe my technology is a little choppy, so hopefully you all can hear me. If I lose audio, Brittany and Kimberly, of course, can take over where I left off. All right. So my name is Sarah Lopez. I'm the Vice President of Implementation with Connections Health Solutions. And I have had the honor of working the last probably year or so with many critical stakeholders, learning the continuum of care. And I believe I've presented early on to many of you in the room and online. And so happy today to present to you all an update as to where we are today. We are just a short couple weeks away from opening doors. And so lots of work have been happening over the last 2 years. And we're excited to kind of tell you all where we are and kind of what our next steps are as we are in this final home stretch. Next slide. So we'll start with just our mission. As you all may remember, Connections isn't just a name, it's really who we are. Our entire mission is to provide immediate care to people in crisis and connect them to long-term support within the community that they reside, whether that be in Harrisburg or some of the surrounding cities and other counties. Next slide. I think it's important for us just to level set and remind everyone what the services are that we will be providing and what the walk-in center will have available to patients that are seeking services. So just a reminder to everyone that we will be providing services to both youth and adults. Our mobile response units will be providing services to all individuals. However, the Behavioral Health Crisis Center will be providing services to individuals age 14 years of age and older. We will be providing 2 mobile units that will operate 24/7. Initially, we will have 1 team operating 24/7 and 2 teams operating during traditional hours during the day. Those 2 units will be responding to calls in the Dauphin, Cumberland, and Perry counties. We will be dispatched through 911, 988, and county crisis teams. And we've been working really closely hand in hand with the 988 dispatch units, the 911 dispatch units across the 3 counties, as well as the county crisis teams, to talk through those handoffs, the scenarios that are the most clinically appropriate to leverage mobile services, ensuring that our team is trained and ready to go. And we would be working with those critical stakeholders on responding out into the field. So very excited about that particular service. And really excited that we were able to provide both individuals with lived experience and clinicians that will be operating those mobile units. As far as the walk-in center itself, the services that will be offered at the center will start with urgent care. So similar to how you and I access urgent care today, it's a very similar model in that anyone can walk through that front door and they are met with by a psychiatric provider who is able to provide an assessment to that individual within 90 minutes. If that individual walks in and their needs are met on an outpatient basis, then a plan is put in place and we're working with that patient on what that particular individual needs, what their aftercare plan looks like, etc. That plan is developed and then they're discharged back out to the community, obviously with the plan in place. If someone needs additional time with us or their needs exceed your traditional kind of urgent care outpatient visit, then they're able to move from our urgent care services into our observation, at which point they're met by a multidisciplinary team that consists of psychiatric providers, medical providers, nurses, technicians, peer support, certified recovery specialists, case managers, social workers, administrative staff, etc. All in which are providing treatment and services to that individual at minute one, very intense services at the center. And we are providing care to that individual for up to 23 hours and 59 minutes. We are stabilizing the individual, we're addressing their needs, and then discharging them back out into the community, again, with the plan in place. If that individual requires a higher level of care, we have been coordinating with many different inpatient units in the hospitals to make sure that we have processes in place for those handoffs from the walk-in center to the appropriate next level of care if someone should need additional services beyond 23 hours and 59 minutes. I'll get into that in one slide, in the next slide. And then our last service is that we will have a transitions program that really works hand in hand with the case management units and the CMU units there in Dauphin that are also co-located with us in that building. And that's really to ensure that we're leveraging the resources and support that already exist today. We're not duplicating those efforts. And for those patients that are enrolled and engaged in case management services, we want to engage that case manager and pick up right where that individual left off with them to ensure continuity of care and to make sure that the right treatment team is in place and notified, etc. The other piece of information that I will remind everyone is that I talked a little bit about walking in on your own accord. That's what we consider to be our front door. So individuals can walk in that front door space. We also have what we call the back door. That's a dedicated entrance for law enforcement, mobile units, first responders, EMS. And so that's a dedicated entrance for those individuals that can bring patients to us, transfer custody to us at that time. We initiate treatment at minute one and allow those stakeholders to go back out into the community and patrol the community as necessary or needed. And so we have a dedicated space for them to be able to give those patients privacy at the back of the building, as well as ensure that we have a dedicated team meeting them at that back door to for safety purposes and to ensure that the transfer occurs to us. Real quick before we move slides, Brittany, Kimberly, anything that I missed on the service array that we'll be providing at the emergency behavioral health walk-in center or the mobile units?
I don't believe so.
I don't think so. I think you covered it.
Okay, great. Well then, I'll go to the next slide. These are some pictures. For those of you that have been in this space before, I think you'll find these to be a little confusing in the sense of it's hard to imagine the space what it looked like before it looks today. There will be an opportunity for you all to tour, those of you that haven't seen the center before doors open. And again, I'll get into those details a little bit later, but nonetheless wanted to preview and show you all the beautiful space. We've worked with architects and GCs that really understand the connections model, really have kind of taken our vision and brought it to life. We have particular pictures you can see on the walls that are of Pennsylvania landscape, and we're really excited and proud of that. You'll see the colors are warm and welcoming, and the space really is just beautiful. Everything is anti-ligature safe. We work again with behavioral health architects, so they really are thoughtful in their design elements and the materials that they choose as far as impact resistant walls and caulking that is pick resistant for our patients, etc. So just a lot of thoughtfulness going.
Oh,
It's almost gonna be my turn. I can almost.
well, that's good, because she's out. Yeah.
You want to proceed, Brittany?
Yeah.
She may start talking once I get going, but so these are just some additional pictures. Sarah, are you there?
I am here. Can you hear me?
Now,
We can now, yes.
we lost
Oh,
you.
no.
for a moment.
I just
It's
kept
okay.
talking, so I have no idea where you lost me, but
Just moved on to the youth observation floor slides.
okay, great. So the two pictures that you're looking at here, again, is the youth observation space. Although these pictures are beautiful, I can't really wait for you all to be able to walk the floor and walk and see the space in person. It truly is beautiful and warm and welcoming. I'm just really excited to share kind of what the center looks like with you all. So wanted to give you a little bit of a preview. Next slide. I'm going to actually turn off my camera just to try to save some bandwidth. I will turn it off after, or turn it back on rather, once I'm finished speaking to this, but hopefully you all can hear me. Brittany, are you guys still there? All right.
You're good.
Okay, well, then this brings us to the meat and potatoes of today's presentation as far as updates that we wanted to provide to you all. So we'll start with hiring and training. We have had a few successful hiring events to date. Really excited about the general interest from the community coming out to our in-person hiring events that we had in October, as well as in September and in October. So really had a great turnout there. We have hired physicians, nurses, techs, peer supports, mobile therapists, case management, unit coordinators, and all of our leaders. What was really cool about this particular project and the way that we deployed our staff is that we had an opportunity for our leaders that we hired in the Pennsylvania market to actually come to Arizona. And that was something that we had done differently for this community, where we were afforded the opportunity to have our leaders come and see the connections model in Arizona, see it in place. And while we have to adapt and adjust for regulatory differences and for community differences, they really got to see the model in play and to see a full center operating. And so really excited to share the knowledge to understand the model and to see it kind of working. We spent some time with them through policies and procedures and actually seeing us.
Brittany, perhaps it's better if you just run
Yeah.
with it from here.
Yeah.
Yeah, Sarah, can you hear us? Okay, so she left off of the trainers going to Arizona and being able to train and work closely with the individuals who have been, working in the crisis center and doing the work that we are bringing to this market. And I've been able to meet a lot of the leadership team, and they enjoyed it. They're excited, and we have a really great group, I think, of employees that are currently training. As far as the community stakeholder partnerships,
I'm a community engagement specialist with Connections. I was hired in July, so I've been with the team since July, and I was the only employee up until a couple months ago. So I've been to just about all of these meetings, and they've been fantastic. The local hospitals have been fantastic. The 911 and the 988 teams. Mike Snyder from Cumberland has been just fantastic working through different flows with us, making sure that we have all of the different scenarios that, you know, that we can think of, not in practice, so that we can be prepared for what we may see when we go live. We have met with school districts and leaders of the different schools, working closely with Annie's office and Megan Johnston there to make sure that everyone is aligned on how to utilize our mobile unit, making sure that we're appropriately involving parents and making sure that we're a resource, but still utilizing the current resources that are available in the community. We have met with children and youth, transportation providers, community outpatient providers, and also the inpatient providers, really closely with the inpatient providers on what labs do they need, what clearances, so that we make sure that the workup that we're providing them makes it seamless, easier for them to direct, you know, to accept our direct admits, but also easier for the clients to not have to, you know, have the same questions asked and information repeated to them, that it's just a seamless referral. So we have worked very closely with community stakeholders. We are still doing so. I have lots of meetings over the next couple months, and we'll continue until, you know, we're meeting with groups second and third times to make sure everything is going smoothly. Our upcoming events, we have our first responder event, ribbon cutting, and then a community open house coming up here in the next couple weeks. So invites for those have gone out. If there's anyone who hasn't received them, that needs them, we are happy to get those out. There are potential date changes in regards to maybe the ribbon cutting event, but that communication will come out clearly from our team. And as far as post opening, so our open date is December 4th. And then shortly after that, I will be having a baby. So there will be Kimberly Jones and Sarah. They will be stepping in as far as following up in the community to make sure that what we have been sharing with the community is the service that we are delivering. Something really important to Connections is that real-time feedback. You know, so if we're saying at our back door, we want to see an under 10-minute response time, and an officer comes to our back door and it's 12 minutes, 15 minutes, we want to make sure we're receiving that, you know, feedback in real time, so we can check our cameras, check in with our staff. Is there additional training that needs to take place? But really, we just want to make sure that we're touching base with the community, seeing how things are going, and that everybody knows that we are available, and then check in on the services we say we're offering. Is that what everyone is receiving? Sarah, you're back.
I'm here. I was just listening. The only other thing, can you hear me?
Yeah.
Okay. The only other things I was going to touch on that you mentioned was the ribbon cutting date will change. We'll make sure that you all have that information. And then the last piece around strategic outreach to stakeholders, we're just going to be really thoughtful around ongoing meetings with the community stakeholders to make sure that we are adjusting and pivoting, and we are good partners to the community as we do go live, and making sure that there's fidelity to our model, but we're also meeting the need of the community as well.
Are we ready to take questions, Sarah?
Yes, we are.
Okay. Are there any questions?
Yeah, I'll jump in. So, and I'm not sure who to direct the question. The one thing that Sarah had mentioned was on the slide of the care that's being provided. And when you got to the transition, she said it was going to Dauphin County. So if we have residents from Cumberland County that are already in our care or being serviced, I mean, I want to be clear what's happening there. And Annie, what's your understanding?
Well, Sarah, I think it's because the CMU is co-located with the Walk-in Center.
Okay.
There's work being done with Penn State Holy Spirit as well as Merrickey Stevens Center around those same flows. But, you know, they're very familiar with the CMU because they're right upstairs. And I think, so Sarah didn't mention Penn State Holy Spirit or Marrakey, but there have been meetings here in Cumberland County specific to that. In fact, tomorrow there's also Friday, I'm sorry, a
Yes,
meeting
we are
around the flows with our case management units. And those are things that are still being worked out, but there have already been meetings around that.
I think it's certainly a language piece too. I think when Sarah said case management units in all of the counties. So we're going to make sure that we have flows appropriate to the base service units in Cumberland Perry as well as Dauphin. We'll cover it all.
Because it would seem to me to be very disconcerting for somebody to be there in a emergent situation and then be placed with people they aren't familiar with or
Absolutely.
trying to be placed into a different system.
Absolutely.
So, okay.
And we've been, I've taken on the task where we're creating referral binders. So we will have referral services and flows for each county separate. So when an individual comes in from Cumberland County, from Perry County, our team is looking specifically at what's available in their county and not misstep to make the referral to a different county.
And just to further update our commissioners, I think some of the unique things about this project is when Brittany and Sarah talked about 911 and 988, I mean, literally, we were bringing our 911 partners to the 911 center in Dauphin County to meet, or vice versa. They would come here, and as well as state police would come here to our 911 center. So really, it wasn't just a disjointed process. We met together to have these conversations to work out these flows with our 988 partners, as well as leadership, Penn State Holy Spirit. There's been a lot of work around the emergency room. Sarah and her team, Brittany, they've met with the emergency department, charge nurses at Penn State Holy Spirit, and they've met with a number, all of our surrounding hospitals. They have met with to talk about flow through the emergency department, as well as how best to direct the flow to the walk-in center, including conversations with Dr. Drew Bledsoe from the Department of Health. So we've been working really hard to see, because you know, the Impella laws tell us that EMS can only transport to an emergency department. So the Office of Mental Health and the Department of Health have been working collaboratively to try to set up a pilot so that we can have EMS transport to the walk-in center. So I think I mentioned the UPMC Life Team will be doing that pilot for us. And so we're grateful for all of the various partners that we've developed along the way here and are continuing to develop. The meetings still continue with the school districts. There are meetings with the school superintendents, I believe early in January, so that our school districts will have a greater awareness of the program as well as how to appropriately use the program. Sarah mentioned 14 and up. That's the walk-in center will see young people 14 to 18, 17. And then once they're 18, they're considered adults. I'm looking at Kimberly just to make sure.
Oh, so, yeah,
Not
Sarah got
mistaken.
kicked out, but she's trying to call back.
So, but for children younger than 14, then the mobile teams would be handling those kinds of outreaches.
Yes.
Additionally, like we do with our crisis providers now, people who are receiving higher level of case management supports, our intensive case managers and our assertive community treatment teams and our family-based providers, we provide a list of individuals receiving that service to crisis now. So if there's a crisis contact, our crisis providers are now who receives that service so they can reach out immediately. We'll have the same expectations when connections. So that kind of reciprocal kind of how do we best help this person will be happening in real time. I think I mentioned yesterday that earlier this week, OMSA's policy gave us permission that if a person comes from Cumberland or Perry County to the walk-in center and a 302 is needed, they'll be able to call our delegates. And we're grateful for that so that we can best serve our community. So we're going to be adding that to the language of our current memorandum of understanding with Dauphin County, just to make sure that legal language is there, as well as sharing that the state has given us permission to do this.
I understand that you're coordinating a lot of different people and there are a lot of stakeholders involved in this process, but I really want to emphasize that I think that we do need to establish a plan for status updates to be not just our board, but to all of the commissioner boards that are involved in this project, because the funding ultimately comes from the counties in order to make this work. So I'm emphasizing that. I feel like we have not been as engaged perhaps up to this point as, I mean, I appreciate this update, but would certainly like to receive some regular reporting. I think quarterly, I would hope wouldn't be too much to ask of that. And, you know, in the vein of being good partners to all the community, please be a good partner with us as well.
Sure.
So,
Absolutely.
did anyone have?
Sarah, I hope you guys can hear me now. I just called in.
Yes,
I
Sarah.
apologize for all the technical. Okay. So yes, we can absolutely provide a thorough report quarterly. We want to make sure that you all stay up to speed, that we are good partners as far as keeping you guys aware of how the project is progressing, as well as, you know, the success, as well as some of the hiccups or maybe challenges that we hadn't foreseen when we first kind of initiated the outreach efforts and what have you. So absolutely, we can take that back and make sure that we do a better job of keeping you guys in the know, and that we have a standardized reporting, either meeting structure or information that we can share via email, et cetera.
Thank you.
Andy, I have a quick question, since just for the context for anybody who's not been part of this, could you summarize 60 seconds the funding mechanism currently for this?
Sure. The State Office of Mental Health, I believe in September of 2022, gave counties the opportunity to apply for a grant. A federal grant, Community Mental Health Services block grant dollars is what the funding was. They listed it as ARPA because we were still in the throes of the pandemic. They encouraged counties to collaborate, to regionalize and consider regionalization. And we talked with Dauphin County, decided this was a good opportunity for us to consider how best to do this. So ultimately a $13 million grant, $13.1 million grant was put together, as well as then our Health Choices Board met to talk about funding the renovation aspect, because community mental health services block grant dollars cannot be used for renovations. It can only be used in terms of renovation, just life safety kinds of things. So ADA compliance, which would not cover a whole lot, frankly. So we approved another $5.5 million for renovations of the space. Dauphin County had the space at 1100 South Cameron Street. They felt like that was workable. Connections then, we wrote the RFP and Connections was our provider. We had a small group of stakeholders, including people with lived experience. Our managed care partners, our CABHC partnered with that. We had some of our staff, children's staff, as well as adult staff review the proposal. And ultimately it was Connections. I think it was a unanimous decision that Connections would be our provider. And then the contracts were developed. Memorandum of Understanding was developed with Dauphin County initially and went through all 3 boards of commissioners. And then we developed the contract. So it's been quite a lengthy process. Last year, literally about a year ago, we convened the media event where we announced that we were going to be developing the walk-in center, and you folks were present at that event. And now here we are a year later talking about opening. So it's been an exciting year, lots of hiccups and bumps along the way, and we're still not finished with those bumps and hiccups, we're sure. But it's important that we are trying to align with federal standards around crisis, how to best provide crisis services for our community. And we believe it will be a benefit, because in other parts of the nation that have implemented this model, they've seen a reduction in the use of inpatient psychiatric treatment, as well as helping people to stay well in their community. And that's honestly, that's what it's all about. It's trying to help people be well in their community. So there is a whole lot of work yet to be had. You know, we would love to be able to develop longer term stabilization opportunities. So for both our counties, Dauphin County, they're looking at pure respite options. We have respite options here, but only 4 beds. So internally, we're having conversations of how can we successfully transition people who need greater than 24 hours, 23 hours, 59 minutes. If somebody requires longer than that, how can we then step in and offer that support? That if somebody needs to just make sure they're sleeping, they're eating, they're taking their medicine, that we have staff available to support that process so that they can be successful without the use of inpatient treatment. Anyway, that's a short version of all the work that's been done and continues to happen.
So Annie, I'm wondering your opinion on this. You know that we have an issue with complex case in children and youth. They go into crisis, it's time to release them, there's nowhere to send them. So what will happen if a complex case youth shows up at this center and there's nowhere to put them?
I think that's going to continue, to be really honest.
Okay.
The limitations on this program is 23 hours, 59 minutes.
Okay.
And complex case, I mean, you know, if a child is psychiatrically ill and that's psychiatrically ill, then we would be looking at inpatient psychiatric treatment. Often what the issues are residential treatment options for especially the complex cases that children and youth are serving. Ideally, if we could do a better job on the front side, working with the whole family, I think there's a lot of research that says if we were to better support the entire family, we would not have as many children in need of treatment and support. So I don't know how, as a community, as a system, as a nation, we address these needs. And yet I think it's been clear in terms of clinical studies that that's the best approach.
Well, Annie, I think that's a really strong endorsement for what our director is doing in restructuring her department and adding more resources to that family support to try and prevent those scenarios. So thank you.
Yeah, proactive strategies, literally across the board, what Nikki's doing in children and youth, as well as the work that we're trying to accomplish here. You know, there's been a lot of, I'm going to say, collaboration and how we can work better together. So literally across all of our human services delivery system.
And I would say at the same time, because of some of those situations are family involved, that this will also offer the opportunity for maybe the parents to get that urgent care services and supports that they might need to possibly stabilize the family if that's part of the need, you know, in those situations. So it's kind of multifaceted that way.
So both of these women from Connections nodded their heads at 23:59. What happens at 24 and you don't have a place for that person?
So if it's an unsafe discharge, we're working diligently to.
Yes.
And the inpatient facilities we have started working with in the community and been at the table with are willing to take direct admits from us. So that they're not going back to an ER in a perfect world. It's not, we're going to try to avoid that. It's going to happen because that's the way the system is set up right now. However, we could direct admit when we have youth beds. Youth beds are limited in this area, even outside, even farther out of this area, right? Is what I just relocated here from Arizona 3 weeks ago.
Okay.
So I'm learning. But you know, however, we're never going to put somebody out of the clinic if it's an unsafe discharge and there's nowhere for them to go. We're just not. We're going to continue to work and get medical directors on the phone with each other at the potential accepting facility to work through those complex cases.
And I will say our discharge planning does start at minute one. We have worked with the local emergency departments that if this case does come up, because we are going to see it, we know that we have worked with them on exactly what we will provide them so that they can then pick up and kind of continue what we have already started. It wouldn't restart as if an individual enters the ER and they have to do all of the assessments and all of the work. So if we started a bed search and we're just kind of waiting for a response, we are going to hand them a packet of information that makes that transfer easier for them, easier on the client, and then really just waiting to get that individual to that next step. So we do have processes in place to make that all smoother and as smooth as it can be.
The only thing I'll add is that our intent really is to stabilize the individual at the walk-in center under 24 hours. And yes, those are all the things that we've put in place for individuals that do require that higher level of care beyond that. But we have really shown to be pretty successful with about 70% of individuals that are coming into the center to stabilize them because they are receiving treatment and services at minute one from a multidisciplinary team that are very intense, and we are providing lots of wraparound care to that individual. And that, I think, is what we're adding to the continuum that looks a little different, is specialized behavioral health care by specialized behavioral health individuals at minute one, where we're able to stabilize the person and create a plan in place to keep them safe.
I think the other thing we haven't mentioned too is that the hope of bringing this model into the community is that we do free up some of the maybe inpatient beds that were able to be stabilized at our level, and free up some of the emergency room space so that everyone really is at the appropriate level of care, and then there is space to move within the system.
Yep.
Sure, the health facilities would welcome that. Yes. Anyone have any more questions of them at this time? Commissioners? No, I believe that's it then.
Thank you for having us.
Thank you for coming. We appreciate it. Thank you, Sarah.
Thank you all. Yep, thank you guys.
Next up, we have our quarterly update with Ms. Bletchley, if you would.
These are not some.
Sure.
Right, copies.
Thank
The
you.
last one you'll get for this year.
Thank you.
I try to keep them in the same format.
Just say.
We'll present to you today a very brief update on the 5 projects. So the goals are there on the far left of the screen right now. For each project, those are just the quick summary goals, and then the inside gives you some insight into what's been done since we last met. Quarterly updates, but our last one was July, our third was in July. So we are not 100% done with some of these projects, but we see the finish line. For instance, we will likely have one of them done shortly after tomorrow. We're just finishing up things with the coops, and we are the compensation study. We're promised results by December 19th. So we should be able to see at least a draft of that document, if not the final document. So the genealogy project, that really has been long finished in terms of getting it up and running and available. Now we're still sending staff to training, getting them up to speed on how this works, advertising it to the public, continuing to advertise it to the public and make sure people know about it. And the little quote in there is something that came in from our vendor, as one of the results they got from, that they collected from their feedback on the product. I personally was really thrilled this past weekend. My uncle came to me with 18 pages of paper all about my great grandmother, her father, and how they came over and how they got here and how they settled the Bald Eagle Valley, where it's now lake, it used to be a town. So so anyway, it's been a really fun project, but it's one I've almost forgotten about because we've been long done with that, and it's just become a routine thing that we now do in our libraries. We are constantly looking for opportunities to continue to enhance that genealogy project or any of our resources. The municipal relationships, almost done visiting all the municipalities. We're at 20, we've so far had 26 municipalities that have received at least one visit. Several have gotten more than one visit during the year, and 2 of them get visited monthly. One has had 5 visits. So they all will be visited by the end of the year. Our real objective with this was just to make sure every municipality knows that they are tied to a library and what kinds of services that library has. So one of the things that I noted in here was, in addition to, I believe at the last meeting I may have reported, one of the municipalities expressed interest in a story walk when the director went there. Another one doubled its gift. It's not a huge gift, but it's twice as much as they were getting. So So that's, that was really an exciting outcome. The inventory project, again, is kind of one that it's in my rear view mirror at this point, with the exception of getting those inventory wands, which I have pictured over on the far right. We do have a wand and a pad, but we ended up having to do the inventory control the slow, long way. But all libraries did meet their goals for inventory control, for doing inventory of their collections. One example I think I gave you last time was Simpson Library closed for Jubilee Day, and some other days, 4th of July, they were closed, and they had they were closed extra days, and they just did their whole collection. So it was a little slower than we thought it was going to go, but we do have a working inventory wand, and the company is working to get us more. And it continues to be an industry-wide issue. There is no vendor who could have done it any faster. So that's, I guess, reassuring. The compensation study, as I mentioned, we will see the results of that on December 1920 is the timeline for completion of that. But we've been working closely with R.C. Kelly Law Associates on that. They have a business counsel services, so they're not just a law firm. She specializes in compensation studies, Grace Kelly, and her coworker Sandy Steelhammer, who's the mathematician, and so she's running all the numbers. But they've been working with our data sets, so they've been collecting things like our staff, the nature of their jobs, the level of authority somebody has, the years of service, and of course, their compensation. And then they've collected retention information, turnover information. They're compiling all that with key data sets from outside, from external sources as well, so that they can compare both to external competition and also to external library workers. What do things look like in the library world? She also pulled up for me the MIT fair wage standards to show me that in comparison as well. So I got a really nice preview from them the other day, and they what they did for us was they amalgamated and anonymized the data so that you can't look at the data and see what an individual is making. But you can get a sense of, for a circulation person in our libraries, here are the lows, here are the highs, and here's where they should be. So that's nice that we're keeping that information private. But we did do it for 196 positions, which is about right. That's practically every staff member in our member libraries. We didn't include the library systems as they're under the county's HR. But that included 156 part-time and 40 full-time staff. And one of the very first trends that I noticed, and she said, yes, that is what you're seeing, is the high turnover rate, which isn't a big surprise to me, but most of our about 50% of our staff are 3 years or fewer on the job, and they're leaving. So they're using us as a training ground to learn technology, learn business practices, and then go on to something new and different, which isn't always bad, but it does mean that's an expense to us to have to hire and retrain new people. And the other thing that the low wages, I don't think I put any facts into this one, but I shared that with my board that I believe 86% of people are making less than, what she showed me was what a single person in Cumberland County with no children, what they would need for a living wage. And 86% of our staff were making under that, which was really eye-opening. So, and that included, I believe, 17 full-time staff members. So the inefficiencies, I handed this out at my board meeting, as somebody said, what does that mean, inefficiencies? Inefficiencies was number of hours worked, just mostly what we talked about there. The fact that we have some positions where people are working very minimally. And she's going to be giving them some counsel in what that means in them and their boards. What does that mean in terms of communications and how that creates an inefficiency? If your staff member's never there or needs to use half their work time to check emails, they can't really do the rest of the job so well. So she's going to be providing them some background so that they can take that data, those library directors can take that data back to their boards and explain, you know, better justify a higher compensation or changes to their staffing patterns or whatever change they might need. So each library will use the information to customize it to their situation. And the last project is the continuity of operations plans. It was shocking that our libraries, some of our libraries didn't even have emergency plans. It was wonderful to meet with Michelle from the Department of Public Safety, get a lot of good information there. It really hit home when those floods hit Western North Carolina or even the ones in Trout Run, Pennsylvania. You know, what can happen so fast. The Ohio train incident that happened a few years ago. I think about the train that goes right past Simpson every day. California and Hawaii fires, and the Hawaii one where the library disappeared in seconds. And so I think those instances really bringing Michelle's going through some of these things, thinking about tornadoes and gas leaks and all the terrible things that can happen, how we can keep our businesses up and our libraries up and running, how we can relocate staff, how we can re-implement technology. One of the most powerful messages was, it's not necessarily about us and our jobs, it's about our communities, because they are the ones that are really at a loss. And I'm not talking about they need a fiction book, although they might want that for relaxation later, but they're gonna need internet to connect with their families and say, I'm safe. That we can be a place to, you know, we can provide places to, we can redirect our resources to help the community in community crisis situations. But first we have to have the plan to be able to do that. So the end result of that will be a document. They of course will have their own continuity of operations plans, but I will also have something that that combines all of their information so that at any given moment, if something happens and nobody knows, who do we call, what do we do, I've got at least a base plan with me. Most libraries are saying things like, we're gonna give you a copy, we'll have one on a server, you'll have a hard copy. So so we're getting there with that, and that's been like I said, a very eye-opening and important exercise for us. So that's my quickest I could do. Do you have questions about any of these at all?
Carolyn, my only comment will be on that, those continuity plans is just having a tickler at some point to make sure that staff double check them to update them on an annual basis, no matter what that each library determines that it is. But they're great to do, but then oftentimes they get stuck on a shelf.
Right.
And I know this plan you'll stop reporting on at some point, and so wouldn't want to see that not become something they keep an eye on.
Yeah,
So
definitely.
it also seems as though some of the libraries might be a good place to be the hub for services if they're needed in the community as well, if there were an emergency.
Yeah, I just came back from a conference where we were talking about, we started with the base book called Libraries 2035. So that's, you know, thinking about the future, and the person I was sitting next to comes from California and now she's in Illinois, but lots of events that she's lived through, floods and fires and such. And she said they had generators at all of their libraries. And I was like, that's interesting. And, you know, thinking about running our business. And that's when, you know, she drove home what we've been thinking is being available to the community, being the community resource. She talked about MOUs with emergency services to set up operations. And Bosler had even said, we could put showers in our parking lot. If something terrible happened that we needed mobile showers, we could do that. So there's a lot our libraries could be doing. Yes, for themselves, but also to extend services to the community.
Thank you.
Welcome.
And on one other note that I had on the compensation study and talk about living wage. The United Way has done a really deep dive on that too. If you haven't seen
The Ellis.
yeah, if you
Yeah.
haven't seen anything on
Yeah.
that, that's some good information.
We definitely use that as one of our key indicators.
Okay,
Yeah.
so you have all that. Perfect.
Thank you.
Thanks, Carolyn.
All right, is there any other business to come before the board at this time?
No, I'll move to adjourn.
Sounds good. We are adjourned.